Ventricular fibrillation, VF, has no discernible QRS complex. Treatment for VF is immediate defibrillation. Ventricular tachycardia, VT, if stable, is treated with amiodarone. Unstable VT is treated with synchronized cardioversion. Pulseless VT requires defibrillation. Atrial fibrillation has an irregular heartbeat with no discernible P waves. It is treated with diltiazem, verapamil, digoxin, or amiodarone. Atrial flutter is characterized by sawtooth-like P waves. The heart rate is commonly around 150. Rapid atrial flutter is treated with calcium channel blockers or beta blockers. Torsades de Pointes is a type of polymorphic VT due to prolonged QTc. It may degenerate into VF and can be treated with magnesium sulfate or electrical cardioversion.
The 6 links in the adult out-of-hospital chain of survival are: 1. Recognition of cardiac arrest and activation of the emergency response system, calling 911 in the US. 2. Early CPR with an emphasis on chest compressions. 3. Rapid defibrillation. 4. Advanced resuscitation by emergency medical services and other healthcare providers. 5. Post-cardiac arrest care. 6. Recovery, including additional treatment, observation, rehabilitation, and psychological support. A strong chain of survival can improve chances of survival and recovery for victims of cardiac arrest. High-quality CPR involves considering the following factors: chest compression fraction, compression rate, compression depth, tidal volume, and chest recoil between compressions. These elements are essential for high-quality CPR and improving the chances of survival and neurological outcomes in cardiac arrest victims. Maintain chest compression fraction above 80%. Maintain chest compression rate between 100 to 120 beats per minute. Maintain chest compression depth of at least 5 cm in adults and at least 1/3 the AP dimension of the chest in infants and children. Avoid excessive ventilation. Allow complete chest recoil between compressions to increase venous return to the heart. If a patient is unresponsive and pulseless, perform high-quality CPR. If the patient is in VTAC or VFib, apply defibrillator and shock the patient with 120 to 200 joules biphasic. Continue high-quality CPR while others are attempting to establish IV or IO access. After 2 minutes of CPR, check rhythm. Shock the patient if he is still in VTAC or VFib. Continue CPR and give epinephrine 1 mg every 3 to 5 minutes. After 2 minutes of CPR, check rhythm. Shock the patient if he is still in VTAC or VFib. Continue CPR and give IV amiodarone or lidocaine. After 2 minutes of CPR, check rhythm. If the patient attains ROSC, provide post-cardiac arrest care. In atrial fibrillation with ventricular rate greater than 110 beats per minute, diltiazem may be used to reduce the ventricular rate by blocking calcium channels in the atrioventricular node. The typical dose of diltiazem is 15 to 20 mg IV over 2 minutes, followed by a second dose of 20 to 25 mg after 15 minutes if needed. Avoid diltiazem in the following conditions: WPW syndrome or other accessory pathway. Heart failure with ejection fraction less than 35%. Second or third degree AV block. Sick sinus syndrome. Severe hypertension. If hypertension occurs after diltiazem use, give calcium gluconate 2 grams IV. Calcium administration does not reverse AV block. Prepare 2 syringes and connect the 2 syringes using a 3-way stopcock. Administer adenosine as a rapid intravenous bolus and then promptly and simultaneously flush with saline by opening the stopcock. Elevate the patient's arm to expedite medication delivery. Observe for therapeutic response or adverse effects. The first dose of adenosine is 6 milligrams rapid IV push, followed by a 20 cc normal saline bolus. If the patient's rhythm does not convert out of SVT within 1 to 2 minutes, a second dose of 12 milligrams may be given.
Avoid over-reliance on systolic blood pressure. Diastolic blood pressure and mean arterial pressure are better indicators than systolic blood pressure. Avoid a lackadaisical approach. Timely and aggressive treatment is essential, as every minute counts. Initiate norepinephrine early to improve lactate clearance. Do not hesitate to perform cardioversion in patients with unstable tachyarrhythmias, such as ventricular tachycardia. Do not forget to resuscitate before intubation, especially in patients with a shock index greater than 0.8. Push doses of vasopressors may be considered during airway intubation.
ACLS is a systematic approach for the assessment of multidisciplinary trauma care. The primary survey of trauma care focuses on identifying critical conditions by following the ABCDE sequence. A. Airway. Ensuring airway patency and protecting the cervical spine. B. Breathing. Assessing breathing and excluding tension pneumothorax. C. Circulation. Evaluating circulation and stop bleeding. D. Disability. Check Glasgow Coma Score, muscle power, and pupils. E. Exposure. Undress the patient to check for wounds and keep the patient warm.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.